right? Good. Okay. All right, so we'll get started. So I have a little clip up there. It says you've got a rare condition called good health. Frankly, we're not sure how to treat it. So primary prevention is the first definition that's important to know. It's the preventing the onset of disease. All right, you should all know prevention by this point. That's the basis of our job. Okay, so what are some of the methods or products that are available to prevent decay? Shout it out. Good. We've got fluoride toothpaste, we've got fluoride mouth rinses, we've got brushing, flossing methods, right? Fluoride toothpaste, mouth rinses, xylitol, and fluoridated water, okay? And we have sealants, okay, which we're going to talk about today. So how effective are those methods that I just talked about, as far as your fluorides and your home care techniques, how effective are those at preventing decay in the pits and fissures or the grooves of the back teeth? Not very. Right. So, reason being is the grooves are deep. I always use this when I'm talking to my patients, so just kind of take this in. When I'm talking to my patients about sealants, I say your grooves of your teeth are like this. When you brush and floss, you can clean out the top part of the groove, but the bacteria gets way down in those deep pits, and we can't clean it out. So it's kind of like, even though they may be doing everything they should be doing as far as keeping their teeth clean and trying to prevent decay, sometimes it's just not enough, okay? So that's why we recommend sealants. So fluorides are the best for smooth surfaces of enamel and cemento. So your buccal and lingual surfaces, your fluorides are going to be great, and your brushing and flossing methods, okay? But the majority of decay occurs in those pits and fissures. You see occlusal decay all the time, right? Everyone has seen occlusal decay probably in clinic by now, I would think, right? All right, so a couple definitions that you need to know. Our pit and fissure sealant, it's a thin resin or glass ionomer coating placed into the pits and fissures of teeth to act as a physical barrier to oral bacteria. Okay? Next is a preventative sealant. So sealants are broken up into kind of two categories. We have a preventative sealant, which is placed in the pits and fissures that are caries-free. And then we have a therapeutic sealant, which is placed into pit and fissures with incipient carious lesions that will halt the caries process. Any questions about the definitions? Great. Okay, so protection from caries approaches 100% when the pits and fissures remain completely sealed. So if the sealant is placed properly within the tooth and the grooves and pits and fissures of those teeth, and it's completely sealed off, it approaches 100% to preventing decay, which is awesome, right? All right, so the primary preventative effects of sealants, they provide a mechanical barrier to the pits and fissures, so they're going to seal it off, cover it up. They eliminate the environment conductive to Streptococcus mutans, and they make the occlusal pit and fissure easier to clean by toothbrushing and mastication. So, like I said, you have your grooves like this. If you seal it up, now when your toothbrush brushes, it's not going to have to get way down in those grooves. It's going to be able to just kind of sweep it right off the surface. Okay. So, the purpose of the sealants, again, sealing off those pits and fissures. It's going to prevent the oral bacteria and their nutrients from collecting in the pits and creating the environment that cause caries. It's going to fill the pit or fissure as deep as possible and provide tight, smooth margins at the junction of the enamel. So the margins must be sealed and tight in order for it to prevent that bacteria from getting under there. And sealants do not bond directly to the teeth. Instead, they're retained by mainly adhesive forces. So we'll get into this as we continue. We're going to talk about the etch and how it creates like micropores in the enamel surface to help to bond the sealant to the tooth. So the purpose of acid etch. So acid etch is, we use it in order to produce irregularities or the micropores, like I just said, in the enamel. It allows the liquid resin or the sealant material to penetrate into the micropores and create a bond. Okay. Etchants are placed on the occlusal surface prior to the placement of sealants. The etch can be either liquid or gel, and once the tooth is etched, it will appear like a chalky white color. So you can see in this picture, the tooth kind of looks, it's like whitish, chalky-ish. It doesn't look normal. So when you blow the air on an etched tooth, that's how it's going to look. Okay, and that's what you want it to look like. That's how you know that the etch has done its job. So the criteria for ideal sealant material is that it can achieve prolonged bonding to the enamel, so we want them to last long, all right? We want them to be biocompatible with the oral tissue, so they can exist within the mouth without causing any harm. And they offer a simple application procedure, so they're easy to apply. We don't want something that's going to be really complicated and hard to do on our own. And we want it to be free-flowing and have a low viscosity. All right, we want it to flow nice and easy into the grooves, and really be able to get down into those deeper grooved areas. And we want it to have low solubility in the oral environment. Okay, so for sealant retention, the surface of the tooth must have maximum surface area, have deep irregular pits and fissures, and be clean. And it also must be absolutely dry at the time of placement, and it has to be uncontaminated. So we want to limit the amount of saliva possible, okay? So dry, clean, nice deep grooves, and no saliva. And we'll talk about all the ways to prevent all of this stuff and the procedure in which we're going to place the sealant. Okay, so just a couple other kind of terms you might hear thrown around. So a liquid sealant is also known as a resin, is also known as your monomer. Okay? It goes through a process called polymerization, in which it becomes a hard sealant or a polymer. Okay? Did anyone get that? Okay. So who are we going to place the sealants on? Who do you think we should place sealants on?
Kids first.
Good. Who else? Good.
College students.
Good. Good. So really, I recommend sealants for everybody. Sealants are preventative. So anyone who wants preventative services, recommend sealants. It's not going to hurt them. It's only going to provide them greater benefit. If you want to prevent disease, this is a great way to do it. I know at the practice that I worked at, we were big in prevention. We recommended sealants to everybody. Anyone who had unrestored posterior teeth, we would recommend sealants. As long as, they were, the deeper pits and fissures, anywhere where there could be a cavity, we want to recommend it. Whether they did it or not, that's their choice. But as long as we're recommending those preventative services, then we're doing our job to the best of our ability. Yes?
Since it's a preventative service, do most insurance companies cover, or only if you're under 18?
So typically, it depends. Every insurance is different. Usually they cover first and second molars up to 16. It depends on the age.
Depends on your insurance.
Yeah, it depends on insurance. Usually between 16 and 18, they'll cover like first and second molars. Some insurances will cover all posterior teeth, so premolars and molars. And most insurances do not cover them for adults. But I know the office I worked at, we gave a discount. Like if you wanted to do all of your sealants, it would be $35 per tooth. So, and some insurances give discounts as far we follow their fee schedule.
My insurance wouldn't even cover
So,
fluoride.
What was that?
My insurance wouldn't even cover
It doesn't for
fluoride
adults usually.
after 18, yeah.
Correct.
Yep, most
Like
it doesn't.
50
But
bucks, yeah.
those people that value their teeth and value prevention are gonna want to do everything they can. And we don't have a lot of adults that do sealants, but I've had a good number. And they don't always do them all at once. Sometimes they'll do like one at a time. Every time they come in for a cleaning, they're like, "Oh, I'll do a sealant today," and at least they're getting them. And then we keep up with them over time, and we make sure that they're providing the best for them.
That's a point taken. Like, just because it's not covered by insurance
Doesn't mean
you shouldn't recommend what the patient needs.
Right.
For example, I was very proud of my daughter. Went in for her prophy the other day, and I usually clean their teeth, but she was overdue, and I'm not at work there, so she went in with the other hygienist, and she said at the end, "Am I not getting my fluoride treatment?" And she's 21 now, and she said, "Well, I see that your mom gave you one last time, but it's not covered by the insurance." And she's like, "I want one," because we just pay for that. Because so it depends. If you educate your patients and they value it, you're going to say, "Remember, this isn't covered by insurance, but I think you really should have it. You're at high risk for decay. You know, if you've done your Cambra, you have recession everywhere. You know, it's recommended for you."
And patients will often appreciate that you offer it to them, because a lot of times, you know, if you're at you go in for an appointment, how many of you have been offered to have sealants as adults? Probably not many. They don't, a lot of people don't do it. But
just because it's not covered doesn't mean you don't tell them about it.
Yeah, you can do sealants in the clinic. We have all the stuff to do it. If you want to offer that service to your patient or they're interested in it, I mean, they're pretty cheap here too.
Like $15.
$15. I think $15 a tooth. I mean, you can't. That's a great deal. So it's something, it's prevention. If your patients are, it's a good thing to offer, and then you let them decide whether that's something that they want for themselves or not. Okay, so indications, everyone I said, but mainly you're going to do your children with newly erupted teeth, anyone whose lifestyle, developmental, or behavioral patterns, physical or emotional development, or lack of fluoride exposure puts them at high risk for caries. So anyone that's high risk, okay? Older individuals with reduced salivary flow. So anyone, we just had that discussion with the hyposalivation and xerostomia the other day. Those patients are great candidates for caries. Great candidates for caries and great candidates for sealants. Anyone who desires the application for, and where it's feasible. Okay, yes.
It's actually $10 per tooth in our clinic mail.
Okay, there you go. I mean, you can't beat that. That's a great deal.
Okay.
Yeah.
So, if you have patients and you want to, yes.
So, you said that we can place in clinic? Okay, because I don't remember where I heard it or when I heard it, but it was like this week or last week that they said we usually don't have the material in clinic.
We sometimes, if you want to place sealants, let us know.
Okay, because I have a client who
that's fine.
is
we offer it. It's on our services, so we can do it.
But we just want to make sure we have up to date material, obviously, because we don't always have a full stock of it. Like if y'all want to do it on the same day, because you do most of your stuff on the van.
Right.
But yes, if you let JC know that I have a patient coming in 2 weeks from now, we'll make sure we're stocked.
Yeah.
Okay. Yeah, because I have them scheduled, but I think it's not till October.
Okay. We'll make sure we have some.
Okay.
Okay, and then incipient decay is also an indication. And clients undergoing ortho. Okay, we all know the importance of home care during ortho. And anywhere where there's a deep groove. Okay, so contraindications are going to be patients with behavioral characteristics or cooperation issues. Now, sometimes these patients can really benefit from sealants. So I encourage when you get out in private practice, if you ever have a patient that really would benefit from them, but you have a really difficult time working on them, get someone to help you. Ask for an assistant to do sealants. If you absolutely, I have had a couple patients who have, had autism or, any other disability where they can't really sit still or they can't really open. I mean, even the younger kids sometimes are difficult to work on. They can't really sit still. They're always closing their mouth. Use everything you have to help you. Ask for an assistant. If that's not available, use a bite block, okay? The little mouth props that will hold the mouth open. That way they don't have to hold it open themselves. Yes?
Do we have them in clinic? Bite blocks to use? Where are they located?
I believe they're in the drawer right next to your cabinet with your instruments, right to the left, one of those two drawers. They're autoclaved. We have styrofoam ones, and we have autoclaved bite blocks.
So there's lots of tools out there. I wouldn't say that this is necessarily 100% contraindication, because you want to try to do everything in your power to get sealants for, the kids that maybe have some disabilities or cooperation issues. So anywhere where there's clinically evident decay, you're not going to place a sealant, obviously. Proximal decay, until it's restored, you don't want to place a sealant. And if there's, like I said, I was saying with the MO filling, if the filling is only on, goes slightly onto the occlusal, there may still be some grooves that can be sealed, but we want to wait until after that restoration is done. Insufficiently erupted teeth, so anything that's only partially erupted, we want to wait. Primary teeth with a short life expectancy. So if you have a kid whose tooth is mobile, ready to come out, you don't want to place a sealant on it, okay? You just wait until that tooth comes out, all right? But I have seen kids that have really deep, posterior grooves and pits and fissures, and they would really benefit from sealants. It's not often that you'll seal primary teeth, but it's definitely something that can be done. And radiographic evidence of decay. So any decay, we'll seal. Again, the self-cleaning pits and fissures, that's just for, again, those kids who have those primary molars still and they're not as deep. Usually primary teeth, the grooves aren't quite as deep. If they're able to clean themselves and you're not noticing, staining and there's not food or bacteria getting collected on them, you're probably not going to seal them. And anyone that's allergic to methacrylate, it's a substance that's found in the sealant material. So we want to avoid, obviously, placing the sealant with anyone who's allergic to that. Okay, and then we already talked about if there's a previous restoration. All right, so the teeth with the highest priority for sealant placement are usually going to be your first and second permanent molars. Okay, those are the teeth that have the most pits and fissures, the deepest grooves. They're going to be the ones that will have the greatest benefit. They'll have the greatest benefits for having sealants placed on them. Let me see if I can pull up this video. I have a video on sealant placement. I'll have you watch, and then I'll kind of go through each step too. Give me 1 moment.
So it wasn't working, the link?
So once you load it from the link.
Applying light-cured photopolymerized sealants. Deep pits and fissures in teeth are risk factors for dental caries. A pit and fissure sealant is a thin plastic coating of an organic polymer, resin, placed in the pits and fissures of teeth. The sealant acts as a physical barrier to oral bacteria and carbohydrates, thereby preventing dental caries. The equipment needed for this procedure is as follows: sealant kit, personal protective equipment, protective eyewear for patient, light protective shield, mouth mirror, explorer, low-speed handpiece or air polishing device, bristled brush, rubber dam, optional, dry angles and/or cotton rolls, air-water syringe tip, saliva ejector, hydrophilic primer, optional, light cure unit, high-speed evacuation tube, articulating paper, round finishing burr, gauze, floss, pumice, and fluoride.
Some of this will vary slightly.
With the patient in supine positioning, assemble the sealant armamentarium according to the manufacturer's instructions. Provide the patient with protective eyewear after you have donned all personal protective equipment. With an explorer, identify the tooth or teeth to be sealed. Polish the intended surface with a slurry of pumice and water, using an air polishing device or a bristled brush attached to a low-speed handpiece to remove any deposits or organic debris. Do not use commercial pastes, which may contain coloring, flavoring, glycerin, and fluoride that interfere with sealant bonding. Rinse with water. The teeth can be isolated either with a rubber dam or by placing a dry angle over Stenson's duct, or by inserting cotton rolls. Dry the site to be sealed with compressed air to ensure that the tooth surface is free of oil and moisture. Apply phosphoric acid to the clean and dry tooth surface. Etch the tooth for 10 to 20 seconds. If you are using liquid etch, apply it with a brush. If you are using a gel etch, apply it and leave it undisturbed. Acid etches the enamel to produce micropores into which the sealant flows and hardens. It is mechanically locked into place.
You'll want to retract the patient's cheek while you're doing this and their lip. And, well, after they put it on.
Yeah, just on the saliva ejector. I would have.
And and normally you'd have the saliva ejector in too, to make sure.
Rinse etched surfaces for 30 to 60 seconds using a water
So that it
syringe
doesn't
and a
get
saliva
wet.
ejector. If gel etched is used, rinse for an additional 30 seconds.
If you can use the
If
high-speed
the etched
evacuator,
surface becomes contaminated with saliva, re-etch for 10 seconds. Replace cotton rolls or dry angles as they become wet because moisture interferes with bonding and retention. Dry the treatment site with compressed air for 10 seconds and evaluate the etched surface. A properly etched area appears white, dull, and frosty. Apply hydrophilic primer if available and dry with compressed air. Apply liquid sealant over the pits and fissures. Allow the sealant to flow into the etched surfaces.
and they use a little brush there. I usually use my Explorer to kind of allow it to get into all those things.
We have those little micro brushes.
Apply the light cure tip to the sealant. Place the tip of the light source 2 millimeters from the sealant. The curing process of the sealant is initiated by the light source. Time varies from 20 to 30 seconds, depending on the manufacturer's recommendations. After the polymerization process, evaluate the sealant with an Explorer and check for a hard, smooth surface and retention. Air bubbles should not be present. A set sealant appears as a thin, polymerized film. If imperfections are noted, such as incomplete coverage or air bubbles, re-etch the tooth for 10 seconds. Wash and dry the teeth and apply additional sealant. Remove the dry angles or cotton rolls. Check the occlusion with articulating paper to detect any high spot areas. If high areas are present, remove excess filled sealant material with a finishing burr. Minor discrepancies are eliminated by normal masticatory processes. Remove any residual unsealed liquid sealant with dry gauze and floss the treated teeth. Apply a topical fluoride to encourage remineralization of the acid-etched surfaces. Document the procedure in the patient's record, including the type of sealant used and the teeth sealed. Evaluate sealants 3 months after the application and at every continued care appointment. If the site was contaminated from faulty technique, partial or complete loss of the sealant material occurs within 6 to 12 months. Complete retention of sealants has been documented up to 10 years.
Yeah, so there's some minor things that I'll talk about that we do slightly differently, but generally that's the procedure for sealants. Does anyone have any questions about that procedure before I continue? Okay, so like I've said already, sealant retention is dependent on good sealant placement, okay? So how well it's retained is going to depend a lot on you, okay? So when you're doing sealants, you want to treat each quadrant separately. Don't try to do like a sealant on the right side and then a sealant on the left side. You want to do, like, you can do probably 2 at a time, maybe 3 in like one area. Okay, you don't want to do too many because it just increases the time that it's going to take, the time that the patient has to stay open, and the amount of time that you have to keep it dry. Okay? You want to follow the manufacturer's directions. Like I said, everything's going to be different with increased technology and increase in the quality of products. You know, it may be different. Like I said, I had a 3-second curing light. It was the greatest thing in the world. My sealants would be cured in 3 seconds. You know, and that's awesome for patients. You know, because, again, it's less time that it takes that they have to stay open and we have to keep it dry. Most of the lights are 20 to 30 seconds, and most materials will cure in 20 to 30 seconds, which is what they said. So you want to ensure precision in each step, okay? And always maintain a dry field. Use what you have to keep it dry. We have dry angles in the clinic, right?
Mm-hmm.
You'll have dry angles on the van. Dry angles will be your best friend during sealants. They're fabulous. Usually I do dry angle and cotton roll just to kind of pull the cheek away from the area that I'm working. You can see there the dry angle. I mean, it's great. It keeps everything nice and dry. And then if you add the cotton roll in there too, it just kind of retracts it a little bit for you so that you can really see everything and make sure you get all of the grooves. And you're going to make sure you explain the procedure to the patient. Okay, so step 1 is going to be cleaning the enamel. Okay, so there's a couple different ways that you can clean the enamel. Okay, so number 1, you can use hydrogen peroxide. All right, number 2, you can use an air powder polisher. Did you guys have that in lecture at all? No? Okay. So you'll learn what that is. It's really cool. And you can use the air powder polisher for that. You can use like an acid etch that helps to condition it, or it's a conditioner that helps clean the enamel. You can use a pumice and a bristle brush on the slow speed, like you saw in the video. Okay. Again, you don't want to use the prophy paste. You want to use like the pumice. That's the way. And this is private practice. It's like a gritty prophy paste without any flavor, without any like additives. How would you describe it?
It's like a powder. You would have had it in the polishing lecture, little module that you did for Ms. Terzo last semester as an ingredient, but it's flour of pumice. So we have like a powdery substance, and you add a little bit of water to it, and you make it into a paste. It's gray, flavorless.
Mm-hmm. They also make it, like when you're in private practice, you may see it in like a prophy cup. Mm-hmm. Like they make it in a prophy cup sometimes. It's like tasteless, odorless, colorless.
Very gritty. So you would use it's really good like on stained areas that nothing else is working. But it's not something we would use because it's more abrasive. Right. But you want to get in there and be able to get out everything out of those grooves.
So that's an option for you, okay? What we're going to learn and what we're going to use, what you're going to use on the van is simply going to be a wet toothbrush, okay? So you take a wet toothbrush, you brush the occlusal surfaces really, really well. You use like a suction, preferably the high volume suction, blow air water, make sure that you get any bacteria, debris out of the occlusal surfaces. Check with the Explorer. Make sure there's nothing caught in there. And suction again. And just evaluate it. Make sure that it looks nice and clean. Okay? So simply a wet toothbrush is going to do just as good of a job as everything else. Okay? Yes?
So are we putting paste on the toothbrush?
No. Wet toothbrush.
Yes.
No toothpaste.
Yes.
Okay? All right, so the next step is wash and dry. Okay? So you're going to blow air and water to remove any additional debris. And you're going to dry the tooth for inspection. Okay? So dry the tooth really well. Make sure it looks good. All right? Not seeing anything suspicious. And step 3 is going to be your isolation. Okay, so here, this is where you're going to place your dry angle. You're going to offer them a bite block if it's hard for them to stay open for a long period of time. You also, like I was saying, I usually will put in the dry angle, and then right up here, like let's say I'm working on the maxilla, I'll place like a cotton roll right along the buccal surface of the teeth, like in the buccal vestibule, to kind of separate the cheek from the rest of the teeth. Okay? So, the purpose of isolation, obviously, is to keep the teeth dry. Okay? Have to keep them dry. Use cotton rolls, dry angles, anything that you need to keep those dry. You can use a rubber dam if you have to. We don't use them here. I've never used a rubber dam. I mean, it's very doable with the dry angles and the cotton rolls. So you're going to dry, after you have it isolated, you're going to blow air on the tooth for about 10 seconds to make sure it's dry. You shouldn't see any, like, bubbles. Excuse me, nothing. The tooth should be completely dry. So, salivary contamination of the etched surface is the number one reason for sealant failure. Okay? So, the drying steps are very, very, very important. Okay, so step 5 is your acid etching. Okay, so the purpose of acid etching is to remove any contamination. It has an antibacterial action. It increases the surface area for bonding, and it creates those micropores in the enamel for the micromechanical bond. Okay, the acid etch is usually between 15 and 50% phosphoric acid, and most commonly you'll see it as 37%. It can come in a liquid, it can come in a gel, and it can come kind of somewhere in between. All right, we use the gel. Okay, it comes in a little, it looks just like this. You put a little disposable tip on the end, squeeze it out just like they did in the video. When you etch, you're going to leave the etch on the tooth surface for a minimum of 15 to 60 seconds, dependent on the manufacturer. Okay, so read the directions. It's very, very important. When you put the etch on, you're going to kind of use the tip, make sure it gets make sure it kind of gets into all the little nooks and crannies. You can use your Explorer to go through, and also just kind of like to kind of make sure that you get it in all the grooves. Okay. You don't want to get etch on the tissues. Okay, so you don't want to get it on like the roof of the mouth. You don't want to get it on the lip because it'll kind of create like an irritation, like a burn sensation. So you want to avoid contact with the tissues.
And that's where the gel is like the best thing since sliced bread, because I learned as a student with the liquid, and then that would flow, and sometimes it would flow onto the gingiva. You get this, you get to see, and that was clear. This is blue, so you get to see where it puts. It stays put.
Yeah, it's great. I couldn't imagine using a gel. I've never used the liquid.
But look at the anatomy of your tooth. You need to look at each person's anatomy of their particular tooth where you're putting the sealant, because you're not just putting it on an occlusal. If the OL groove goes onto the lingual, you're going to seal the lingual. If there's a buccal pit, you're not just doing the occlusal of number 30. You're looking, does that patient have a nice buccal pit to seal? Because while we're in there isolating that one tooth, you're going to seal every groove that's there, whether it's on the buccal or the lingual or the occlusal.
And you need to make sure you etch all those surfaces in preparation. Yes.
So if the tooth has like a buccal pit, would you seal it from the occlusal around the pit, or just?
It depends how the anatomy is. If
so
the,
if it has like a connecting groove.
Yeah, right. Then you're going to
Okay.
seal the whole thing. If it's just kind of like a pit, you can seal it separately. It depends on every tooth is going to be different. If it has like a cusp of carabelli, if you're on a maxillary molar, you're going to want to seal that because in that groove you can get decay.
And you'll learn what works for you, but you usually are going to seal or etch all those grooves at the same time because it's just going to cost you more time to go back in and then do it separately. So etch everything at the same time, then place it all at the same time, and you just are going to be using your light, extra long because you have to do everything.
Yep. Any questions about the etch? Sherry also mentioned like the saliva ejector. You're probably going to keep in the patient's mouth the whole time that you're placing the sealants because You don't want any contamination. You don't want saliva, you don't want water, anything to get on the tooth during the sealant process, okay? So my suggestion is, like, you know how you bend the saliva ejector slightly when you're doing, using the ultrasonic? You can do the same thing when you're doing your sealant and kind of, put it in there so that it's collecting any saliva that may be forming, okay? Also, if you have used, like I always use the high volume suction when I do sealants, especially this part, because I know it tastes really bad. You'll all get to taste it on Thursday, but like the etch does not taste good, hence why we don't want to contact any oral tissues, and you rinse it a lot. If you can hold the high volume suction and spray your air water at the same time, it just makes for a more pleasant experience. Okay, so something we'll practice. We can practice it on Thursday when you're in lab. Okay, so after you place the etch and you let it sit on there for 15 to 60 seconds, depending on the manufacturer's instructions, we're going to wash, we're going to dry, and we're going to isolate. So you're going to rinse that etch off the tooth for 30 seconds. Okay? So that's why I was saying sometimes the high volume suction is good because it's a lot of rinsing. It's a lot of water. If you can suck it up in one all at once, it's better. Again, like I said, high volume if possible. You're going to want to change your cotton rolls because they're probably going to get all wet if you're using cotton rolls. Now the triangle, you can usually change that after you're finished, but any cotton rolls are going to be pretty contaminated and gross, and you don't want your cotton rolls to be the cause of a failed sealant. And then after you change your cotton rolls and re-isolate the area, you're going to dry the tooth for 15 to 20 seconds, okay? And you're going to see that chalky white appearance, okay? If you don't see chalky white appearance, you're going to have to do the etch again, okay? And remember, moisture during this process or saliva contamination is the #1 cause of sealant failure, okay? So moisture contamination. When you're drying too, because you're going to be spraying water for 30 seconds, okay, before you go back in to dry, blow your air a little bit, like not in the mouth, so that you know that all the moisture is out of the line, because otherwise you're going to go to blow air on the tooth and it's going to get wet, okay? So just make sure the line's clear. And then you're going to examine, like I said, examine for that chalky white appearance. And saliva is detrimental to the etch surface. Your sealant will not take. You will notice when you check it at the end, it'll just come right off if you have a contaminated tooth surface. Or it will come off within, yes?
I was just thinking, what happens like if I go over here to my cassette and then the patient closes their mouth?
So then you have to and I want to make sure I tell them the right thing. You have to re-etch.
Mm-hmm.
Oh, you have to re-etch.
Yes. Now,
No saliva.
No saliva. You cannot re-etch more than twice in one visit. So let's say on Thursday you etch the tooth, becomes contaminated, so you have to re-etch it. If for some reason it would become contaminated again, you would not want to re-etch again in the same day. And you'll see this later in one of the slides, because it's that demin process, all right? The surface is becoming now so demineralized, you don't want to keep placing that etch on the tooth. I mean, it's acid etch. It's going to cause a problem if you continue to do this. So that at that point, you would place some fluoride varnish on the tooth, wait until they come in 6 months, and do it again.
So you become an octopus. You need 8 hands because you're never.
Literally.
I never take my mirror out of their mouth ever once I start. That's just something I do. And I'll put that mirror in there close to the occlusal surface as a barrier. I keep that saliva ejector in there because they don't tend to close then. But I always have to have something in their mouth.
Yeah, you literally
bite
feel
block.
like you need 20 hands to do this. You'll love Sealant Van when you work with each other because you'll have an assistant. Okay, so when you're on the van, there's 2 chairs for the van, for a Sealant Van, and you kind of pair up, and you work together, which is nice because someone can hand you the saliva ejector, someone can hand you what you need. But when you do it on your own, it's like, okay, I have to hold my mirror and spray water and suction and make sure that they don't close all at the same time.
What you thought we're doing Thursday.
Mhm.
Yes. But it's fine. It's better to do it this way and learn it the hardest way, because when you go on the van, you're gonna be like, man, this is great. This is fun. So yeah, you'll learn. I mean, you'll kind of all learn your own little ways to keep it dry. Like, I know I have my ways that I do it, and I probably look ridiculous doing it, but it works. You know, I just pretend that I have 20 hands. Okay, so, and the other thing, literally. Sometimes I have to ask for an assistant. Like, I know there would be occasions, I usually always use a bite block too, because I find that helps me. But there would be certain patients where I would need an assistant. You know, those of you that get to go to a high school may have a little bit easier of a time working on high schoolers than those that are at an elementary school. It's, it's all going to be a little bit dependent on the patient. Okay? Yes?
After you would clean your occlusal surface with the wet toothbrush and they close, do you have to re-clean it again?
No.
Okay.
No, that's okay. But you would basically just go from that point and you would isolate and dry the tooth and just make sure it's nice and clean.
No.
You're basically just getting any plaque or debris if there's food or anything in there. Get that nice and clean.
And you would do a sealant after you clean your teeth already, usually, right?
In private practice, yes. Like when you're on the van though,
You're not going to clean
right.
your teeth first.
Exactly. Yeah. So usually, like if I'm doing it at a private practice, sometimes I'm not though. Sometimes they come in just for a sealant
Just for
appointment,
sealant.
and they'll be in the hygiene chair. So
Because you don't have time
That
maybe
point.
to do it the day they come in for their
Right.
cleaning.
So
They have
you
their
schedule
exam,
another
they come back.
appointment. Yep.
Hour.
It depends how many you're doing.
Yeah. You
It
want
depends
some
how many
time.
you're doing.
You want some time if you can get it.
Yeah. It depends on how many. If you're
Yeah.
doing a full mouth of premolars and molars, you want an hour because it'll take a while.
Yeah. I just was saying one sealant.
Mm-hmm. Oh, one sealant. Yeah, that doesn't take long. Yeah. All right.
I wasn't thinking about whole mouth.
No, that's fine. Next step. So the next step is we're going to apply the resin or the sealant material. Okay. So now we've etched the tooth. Well, we've cleaned the tooth. We've dried the tooth. We've etched the tooth. We've rinsed the tooth. We've dried it again. Okay. So the tooth is dry. It's etched. So it's right now. You have the patient open. You have the dry angle in, cotton rolls in, and you're going to blow your air. The tooth is going to appear chalky white and nice and dry. So you're going to place the sealant material in all of the pits and fissures, okay? So you place the material, you kind of spread it around with your Explorer so that you make sure that you get it in all of the grooves. Now, Sherry did mention that we have some of those brushes that they had in the video. I'm not sure if they have those on the van or not, but your Explorer works well too, okay? You want to make sure you don't overfill the tooth. Like we were saying, it just makes for more work later because you're going to have to adjust the bite. Yes?
So they'll have everything we need on the van. They'll have explorers and
Yes, you
mirrors
have to bring your safety glasses. Remember
Okay.
that. But they have everything you need on the van.
Okay.
For the
It's
better
actually
to just use safety glasses and
Yourself.
don't bring your loops.
It depends. You can wear your loops.
You don't see very well.
What were they
That's
using on the video to get rid of the overfill?
They used a burr.
Okay.
Yeah, so for us, you're not going to use the slow speed and the round burr. You're going to use your instruments. I know Sherry mentioned it earlier. You can use your 5-6 and kind of take off any extras with that. The material is soft enough that is an easier way, and that's the way that we do it here, that you'll remove any excess.
I just wanted to make sure everyone knew it wasn't like a drill. And we do have,
Right.
hand pieces and stones and things like that we could use if the instrument doesn't work.
Yeah, you would use a slow speed, and you wouldn't be adjusting anything on you wouldn't be adjusting the tooth itself. You'd only be adjusting the material. I know, for me, when I was working in private practice, I used a slow speed handpiece and a finishing burr that I would I would check the bite anywhere where it marked blue on the material itself is where I would adjust. So I wouldn't ever touch the tooth with that, just the sealant material that I had placed.
Oh, that blue paper that you bite on,
Mhm.
it marks the.
Any
High
high
spots.
spots?
It doesn't mark on. I always thought they looked at the paper and I was like, how do they know? It just looks like a.
No, it marks on the tooth. It marks
Wow.
blue on the tooth. So you'll learn, and Joanne on the van, she goes over all that with you. She shows you, what to look for. She tells you exactly what to ask the patient. She always, I think her words were always, does it feel like you're hitting hard? Like, does it feel like you're biting on something hard? Okay? And like even. You want their teeth to feel even. Okay? When they bite together. Yes.
And it might be different when they're laying down also biting than if you set them up in the correct anatomical position. Have them sit up to check their bite if they feel anything that's different.
Are there any limitations after the sealant's placed? Like, can they go and eat Laffy Taffy hormone right away, or are they supposed to like chill with that for a day or two?
Well, I mean, when you can pretty much eat anything. There's no limitations because once you cure it with the light, it's as hard as it's going to be. I mean, I wouldn't really
But our
recommend
patients don't eat
eating
Laffy Taffy.
Laffy Taffy.
Okay.
But it can,
Yeah.
I mean,
Yeah.
I mean, I wouldn't recommend that, but they,
If it would pull out, it was not probably
placed
placed properly.
properly. Right. Okay. Yes?
A question too though, because I noticed one time when a dentist did this, like, and he was wearing his loops, he told me that he always takes the light out of the light because otherwise it'll make
The light will cure. Yeah, so some lights they'll have. Sometimes the light, like if you have like a really bright, I wouldn't use my headlight that I have for my loops. It has a orange shield.
I have
That's what you use the orange shield for because then the light's not going to cure the sealant while you're working on it. It just provides a longer working time. Okay. And some lights, like the overhead light at the office I worked at, had a setting. You could change the setting for the light so it would turn orange and that it wouldn't cure the material. They use that when they're doing like fillings, composite restorations. Yeah.
So what happens if you are placing a sealant and you find that it does cure before you, for whatever reason, if the light was too bright?
It shouldn't cure. I don't know how to answer that question.
It probably won't happen unless you're not, like if someone would be doing a whole bunch of sealants and say have the sealant material open the whole time and it should not happen.
Oh, yeah.
But then you would just have to get new sealant material. You couldn't use that one. It's hard to get another one.
Okay. It's probably not going to happen, in other words. All right. Any other questions? I'll continue. All right. So, don't overfill. Use an explorer to spread the material. You want to take about 10 seconds just to allow it to kind of flow into all of those grooves. And you're going to cure with a curing light. Now, for the first couple seconds of curing, you want to make sure you hold it a few millimeters away from the tooth. Once you get to about 10 seconds, you can rest it against the tooth because it's at the point where it's cured enough that you can rest it right against the tooth that you're curing. Okay? So for the first about 10 seconds, hold it a couple millimeters away from the tooth, but after that, you can rest it against the tooth. Okay? So curing time is 20 to 30 seconds. Always use the dark yellow or orange stick shield. Some of them have the shields built onto the lights. Some of them, we have like a plastic, like handheld one that you hold. All lights are different, but there should be something to filter that light. So after your sealant is cured, you're going to check it for any voids, okay? Like the video said, you don't want any air bubbles. You want to make sure the margins are sealed, that there's no areas where bacteria could kind of collect and cause decay. If there's a void, you can add more material as long as it hasn't been contaminated.
So they can't close.
So they have to stay open. So after the light comes out, don't let them close until you check it, okay? If you check it and it's good, you're good to go. If you check it and it's not, then you can add more material and cure, okay? If for some reason it becomes contaminated, then you have to re-etch and go through the process again. Okay? Questions about that? Yes.
When we're doing this in the clinic,
Uh-huh.
could we have a bipod? Like, I just don't know if I can keep my about them because I'm like,
Yeah.
he said about like a ton
Absolutely.
of like sealant,
Yeah.
and I'm like, I'm gonna sit there
Mhm.
for like an hour
Yeah.
with my mouth.
Absolutely. Yep. Yeah, we have them in clinic. You know, we can use them. I mean, it's for patient comfort, really, but it also makes it easier on the clinician. Yeah.
So are we gonna do each step on multiple surfaces at once? Like if we have like 3 teeth that we're doing,
Right.
Are we gonna do acid edge all 3 and then like?
It
Or are we
depends
gonna do
on
one
how
tooth at a time?
comfortable you feel. Like in the
Okay.
beginning, you're probably not going to do a bunch of teeth at one time.
Okay.
But as you get more comfortable with the process and the procedure, like I'll usually do, like I can, if I'm doing a quadrant, I can usually do a quadrant at a time.
Okay.
But you just have to be mindful that it's going to take longer. You have to keep it dry and make sure that it just doesn't get contaminated. So it's a little bit more complicated. It's definitely doable. I wouldn't say in the beginning, you know, you want to make sure you.
But it will take you, if you can eventually do that and do like 2 teeth at a time,
It'll be
it
quicker
will
in
actually
the end.
be quicker in the end
Right.
than starting from scratch.
Right. Yeah. As you become more comfortable with the process, it will be more time efficient to do it that way. But right now in the beginning, it's going to be easier for you to do one at a time.
Now, if you're doing multiple teeth with the curing part, do you have to have the light like do 1 tooth, next tooth for 30 seconds?
As far as the curing,
yeah.
yes. You have to
So,
cure each tooth individually
cure
for
one, then
20 to
cure the
30
next
seconds.
one, then they cure the
Yep.
next one.
So that's where it can take, you know, in the beginning, like I said, it takes a little bit longer to do it that way, you know, with keeping it dry and, you know. Yes.
If you're doing multiple sealants,
Uh-huh.
should you do like complete 1 tooth at a time, or can you do like both?
Well, that's what we were saying. Right. You can, in the beginning, you'll probably want to do 1 at a time just because you have to keep it dry, okay, and isolated. But as you get more experience with the process, you can do 2 at a time, okay? Okay, any questions? Did that answer your question? Okay. All right, so step 8 is going to be checking for interproximal or occlusal discrepancies. Okay, so you're going to use the articulating paper, so that blue and red paper. They bite down on it, chew up and down, side to side. Oftentimes you want to do this while they're sitting up, like Sherry said, because their bite while they're laying back isn't always the same as when they're sitting up. And sometimes they won't notice it until they're in the upright position, because you don't usually eat laying back, right? So you're going to check for high spots. You're going to use a scaler or a curette to remove the excess, okay? You can, like they did in the video, you know, the slow speeds, once you get out into private practice, if that's what you're provided with, you can use it, all right? Just know that you're using it on the sealant material, not the tooth, okay? You're going to floss in between, you know? You want to make sure that you don't get any sealant material in between the teeth. You don't need to seal the teeth closed. So always floss in between to make sure that you didn't kind of get any lodged in there. And unfilled sealants, so these are your sealants that don't have the filler in them, will wear down to the correct height. The fill sealants, you'll have to adjust, okay? Okay, so then we're going to evaluate the retention. So just make sure that the sealant, like if you use an Explorer, go around the margins, you don't want to like dig at it, but you want to feel it and make sure that it's not going to come off with something like eating a piece of gum or chewing on a piece of gum or chewing on a hard pretzel. Your sealant should be retentive to those forces, okay? So using an Explorer, trace it, make sure that it's not going to come off with that, okay? If it does come off, then you have to start the whole process again, okay? So it can get a little frustrating if, you know, if let's say the patient is a little uncooperative. Then you have to start the process all over again. It takes
But
time.
notice there it says if you have to re-etch, then you can go down to the 15 seconds. You're going
Yep.
down. You don't have to etch as long.
Yeah, so if the sealant doesn't adhere and you have to start the process over, you only have to etch for 15 seconds. Okay? And if 2 attempts are unsuccessful, yeah, to do a question?
Etch right over it, like
Like if the
The
sealant
sealant
would come off.
it'll fall out, like if it's not adherent.
Right. Yeah,
You
you'll be able to like pick it
etch
out with an
over top of
Explorer.
that, would you?
No, you take it out.
You just take it out,
Mhm.
pop right out.
So if 2 attempts, this is what I was saying earlier, if you're unsuccessful with 2 attempts at placing the sealant, you should wait until like remineralization occurs. So just wait until the next time they come in, or 6 months, or schedule them an appointment at a later date. Okay. The next step is fluoride. I believe on the van you're going to be doing varnish after you place sealant. So that was in my email to Joanne yesterday, whether they're doing varnish or like a localized fluoride gel. But from what I understand, the past couple of years they've done varnish. So after you place the sealant, you go over the sealed areas with a fluoride varnish treatment. Okay, just to promote that remineralization. And then maintenance. Okay, check a sealant. You want to check your sealants every 6 months to ensure that they're not becoming deficient. Some offices, as long as they're coming in regularly, they'll replace the sealants as needed. I know the office I work for, we warranty them. If something happens to them or they come off within 6 months, it obviously was, an error within the process. They should last longer than that. We'll replace it. No problem. Yes.
So with the fluoride treatment, you're saying just to apply the fluoride treatment to the sealants, or just give them the whole?
It's going to
fluoride
be
treatment?
just in those areas.
Okay.
Yep.
So why do you think you're doing that? Why are you gonna? Because it was
Yeah.
right. It's to remin the etched areas. Very good.
Yep, good. Okay, so check the sealants. Make sure they're not becoming deficient. So it's important to tell your patients, and you get this question all the time. Well, are sealants like 100% guaranteed that I'm not going to get cavities? Well, no. Nothing's really 100%. But so sealants provide no guarantee that you'll not get caries, but they're an important part of preventive care. And if they're placed correctly, they can have like almost 100% guarantee. All right, it's not always 100 because it all depends upon the patient. Their diet, and we don't seal the interproximals. There's other surfaces of the tooth that can get decay. So it's not 100%, but it's an important process in your preventative care. Okay, any questions about sealants? No? Okay, why don't you take like a 5-minute break? And then
Well, then she didn't. Like I ended up with the. So.
Does
I
it
ended
have
up with
metal underneath it? Because I'm allergic to metal.
the-
So like,
that's a little.
Okay, you ready? You ready? Last section. This should be pretty quick. Very quick. Shouldn't take too long. All right. So we're just gonna briefly talk about the diagnodent. Has anyone ever seen a diagnodent before or used a diagnodent before? Yes. What are your experiences with it?
I haven't used it, but
Uh-huh.
I've recorded the number
Okay.
of readings and
Okay.
minutes and bits together.
Cool. All right. So there's, again, they're becoming more and more popular. They're becoming more and more accurate and technology savvy as they get more advanced. I'll show you a short video on one of them. I've used one before. It's a little bit of a learning curve, but once you kind of get it down, they're a great tool, especially if you're doing sealants. And I'll show you why. So these machines are it's for laser caries detection. Okay, it measures laser fluorescence within a tooth structure. So radiographs are about 67% effective in detecting decay. Okay. Explorers are about 57% effective in detecting decay, and the diagnodent is about 90% effective. So you can see that they're very effective if they're used properly and calibrated appropriately. Okay? Yes.
these percentages in this information, are we gonna need to know that for our test? Just because I don't see it in our manual.
I think it is. Let me just see if she had it.
Might be something you could add to your manual.
Yeah, you can add it. I don't think that it will be tested, but I don't know for sure.
Okay.
It's fair game if it's
it's
on
on-
here that
yeah.
like I didn't look at your learning outcomes. So we'll have to look at that. But that's why another good reason you do a combo.
Right.
Like if radiographs are only, you don't just go by X-rays, you don't just go by Explorer, you combine them.
Yeah,
You
because
did this.
if you combine all of this stuff, you're
Yeah.
going to be over that 90%.
Yeah.
You know, if you're doing a Diagnodent, plus you're using an Explorer, plus you're using the radiographs, I mean, you're going to hopefully not be missing too much. Okay?
We're getting a Carry View.
Oh, we are.
Mm-hmm.
Oh, cool. When?
I'm putting out the bid for it right
Oh,
now.
nice. Good. I've never used one.
So what I was just saying to JC, I have not used it either. We're getting something called Carry View. Now it is called Carry View, but remember when you have, it's like deer and deer. It's plural. It's carries. There's no single carry, unless you carry book. You know, carry. No, I carry book. No, that's not good either. So carries.
I will carry the book.
It's carries. If you have a single tooth that has it, you have carries. It's the disease. It's like saying cancer. It's carries. Okay? Well, that wasn't a good analogy.
Well, you don't have cancers.
But you don't, right, so it's the opposite. You don't say I have cancers. If you had multiple, you have cancer. So carries is the, don't put this on the tape. Carries is the disease. So, but this happens to be Carry View, which is without the S, Carry View. It's something that's going to work with the DEXIS, and it's going to be some type of a wand, that you can bring into your cubicle, and you'll be able to integrate it with, it's from the people who make the DEXIS, and it's going to be something that's going to show like an internal picture, not an X-ray, but kind of using laser and show an internal picture of the tooth, and it's going to show where the caries is. Okay?
What will we be?
DEXIS is your X-ray, the sensor.
DEXIS is
Okay.
the imaging software.
Yes. So this is called. This is from the company that we're going to get a new camera. Also, it's called DexCam.
Oh, those are good.
So we're going to have a wireless camera that can come to your unit, and you'll be able to store pictures, clinical photos of the patient into
DEXIS.
Dentrix. And then we will also have this Carry View. So it's all made by that same company, but we picked that company because it's integrated with our DEXIS X-rays also.
That's pretty cool.
Yep.
Lots of cool technology. Okay, so the Diagnodent is able to detect the earliest possible stage of decay. So it can detect decay when you can't even see it or feel it yet with an Explorer. Okay? It's conservative. It's a conservative way to detect caries because, when you learned how to use like a Shepherd's Hook Explorer, or when you learned how to, explore the grooves of the teeth, you were told, you don't want to push down too hard. You just want to like lightly trace if there's a stick. Well, this kind of eliminates that. So the Diagnodent, you don't have to use that force in the occlusal surface because sometimes you can cause harm and open up that surface when you're using the Explorer. So it's a more conservative approach, which is awesome. So it, gives the dentist and patient confidence in the treatment decisions. Okay. Because of how accurate it is. It's safe. It uses light energy. There's no X-ray exposure. It's easy to use. It takes 5 minutes, and it's accurate. All right. So dentists are detecting 30 to 50% more areas of decay when they incorporate the use of the Diagnodent. Okay. So pretty cool. All right. So this is going to give you some numbers. Okay, so numbers, when you use the Diagnodent, if you get a number between 0 and 14, okay, everything's recorded in a numerical way. So numbers between 0 and 14 require no active care. So this would be, if you wanted to do preventative, you could place a sealant on the tooth. There's no decay if the number is between 0 and 14. Okay. Values between 15 and 20 do not require active care, so it doesn't require a filling, but preventative services are recommended. So it's recommended that you maybe place a sealant in the tooth, you do fluoride treatment, you're recommending fluoride products at home. Okay? So 15 and 20 is still no decay. Values between 21 and 30 require preventative treatment or active care, depending on the patient's caries risk. Okay, so this is kind of like your incipient decay. And this is gonna a lot of times be dependent on the doctor and what you're working with, what exactly the cutoff numbers are. But if you have a number that's between 21 and 30, you're most definitely at least gonna recommend a sealant, if not a filling. Okay, depending on what the radiographs look like. Remember, you want to use like kind of a combined way of diagnosing. You don't just want to use one source. You want to use the radiographs, you want to use your Explorer, you want to use your diagnostic, right? And values that are greater than 30 require active treatment. So anything that's greater than 30 is decay, okay? And that's what's going to be kind of your stopping point for this tooth. Should no longer just have a sealant, it's going to need a filling. Okay? Any questions about the numbers? No? I'm going to play you this video. This is one kind of diagonal. Like I said, with newer technologies, they've got ones without cords, with cords, all sorts of things. This one, I believe, is without. So let me just pull that up real quick here.
We do have one diagonal. Ours has been around with us for a while, so it's going to be an older version.
I'm going to be going over with you today how to use the Dynavet. So first we need to calibrate it. The first thing you do is you turn it on by hitting the top button. Then you hit menu, then you hit this arrow button. When you hear the noise, you're going to place it on a calibration disc. You hear that noise there? At a 90-degree angle until it stops making the noise. Now the numbers should match 93 to 93 on the calibration disc. So to calibrate this in the patient's mouth, you want to use an unrestored tooth. You're going to dry it off. Usually I choose 8 and 9 if there's, of course, no restorations there. You're going to place the tip at a 90-degree angle, and I usually place it on and hold the very tip of the instrument to the tooth, and you're going to squeeze the ring here until you hear 2 consecutive beeps. Just like that. So I have previously cleaned this tooth off with a brush and hydrogen peroxide, or a Profi cup. You just don't want to use polishing paste in the area to clean it. So you're going to take the Dynadent and you're going to set it in the grooves of the tooth, and you do a kind of a circular rocking motion up and back in all the different grooves of the tooth. Of course, you want to make sure the tooth is dry previously, which I did. And then you'll get your numbers, which this is an 11. Every office has different numbers that would indicate a cavity, so just go by what your office policy is.
Materials and
Any questions? So if you ever want to use it in clinic, you can. We have it. It's available. I think it's in 20. Is it
It's
in
in Unit 20.
Unit 20?
It's underutilized by students. Dr. Tom pulls it out a whole bunch. But this is your chance here to use it hands-on with someone so that you can get out and say,
You can use it in clinic.
I don't know if you have a whole lot of time in lab, but
yeah.
if there's ever time in the lab, yeah.
Yeah, that's fine. Any other questions? Okay, so there's 2 papers up here. The green one is due on Thursday when you come to lab. Okay? So green one's due Thursday. The white one, 2 weeks. I think that's
Yeah.
long enough. So the white one is going to be due 2 weeks from today, so the 15th. Okay, so this one requires a little bit more thought and effort. You have to talk to someone who places sealants and write some paragraphs, so that one's a little bit more extensive, okay? But you got 2 weeks to do it.
So you're going to do a little interview with someone, and you're going to write it up, and that one is worth 4% of your grade.
Yeah, if you look at the syllabus, it's worth a good
This
percentage.
is a weighted homework. So take it seriously. It's not just a requirement.
Yes.
Can the person we interview be faculty if we make an appointment?
No.
So we go to an office, pretty much. Yeah.
But you don't have to go. You might be able to phone them, email them, something.
Okay.
Yeah.
Any questions? No? Okay. Awesome. Well, thank you. You're welcome.
Yeah, you get to see us enough, so we won't use faculty.